3, 2, 1.
Welcome back to the Neuroblastoma Parent Global Symposium. I'm Nick Bird, and this session is molecular radiotherapy for neuroblastoma, which is being presented for us today by Dr. Mark Gaze, who is a consultant in clinical oncology from University College London Hospitals and Great Ormond Street Hospital for Children. Before I hand over to Mark, I'll remind you again, if you could pop any questions in the Q&A button at the bottom of the screen. And if it's not immediately obvious, just hover your cursor over it to bring it up. If you see a question you like, give it a thumbs up, and hopefully we'll be able to answer as many of them as possible at the end of Mark's talk. And with that, I will hand over to Dr. Mark Gaze.
Thank you very much, Nick. It's a great pleasure and privilege to be invited to contribute to this global symposium for parents of children with neuroblastoma. So good morning to those in the UK, good very early morning to those in America, and I guess good afternoon to those in Australia and Asia. I've given talks before a little bit like this to normal meetings in the UK and indeed in Australia, but I've never before given a virtual talk at a meeting where over 700 people are registered. So this is quite awe-inspiring, and thank you very much for tuning in and listening. So I'm going to be talking to you about molecular radiotherapy for neuroblastoma, and I thought that the best way of introducing the topic would be with a video that we have made for children and their parents who come to our hospital for this treatment. My name is Mark, it's lovely to meet you, and I'm here to talk to you and to your dad about the treatment you're going to have.
What is MIGB treatment?
MIBG is a medicine. It's a radioactive medicine. Neuroblastoma cells have an ability to stick to the medicine. So once the MIBG has got into your body, then the MIBG goes round and round in your blood, and if it meets a neuroblastoma cell, it sticks to the neuroblastoma cell.
Where will the treatment take place?
You'll come in to the hospital and you'll go up in the lifts up to the children's ward, which is on the 11th floor. And you'll have your own room there. It's got big windows where you can look out and see across London. Just outside your room, there's a bathroom, but it's got a loo and a shower in. And that's all specially just for you. Outside the other door, there's a place for your dad to sleep. So he can be there in the room when you need them to be. This room, it's part of the children's ward. There are the children's doctors and the children's nurses there who will be able to look after you if you need it. But most of the looking after of you will be your dad or your mum. The play specialist will make sure you've got all the books and games and DVDs and toys and videos that you need to keep you happy and entertained.
How does medicine get inside my body?
When the day comes for your treatment, and you'll be in the room in the hospital, and first of all, the nurses may give you some medicines just to make sure that you're feeling very well and to make sure that the MIBG treatment doesn't make you feel poorly. And then people will bring in a big trolley on wheels, a large cart that's got the special medicine in, and that will then be connected up to your wiggly, and then it will drip in slowly. It may take about half an hour for the MIBG to go into your body through the wiggly line. Then the nurses will do things like check your blood pressure and make sure you're all right.
Can I spend time with Mum and Dad?
Your mummy and daddy can spend as long with you as you need them to. They can come into the room, but they have to put on some special clothes. They have to put on plastic overshoes and gloves and aprons so they don't get any of the MIBG medicine onto them. They can be with you for as long as you need. They'll be just round the corner outside. So if you wake up in the middle of the night and you want your mummy, you just call for her and she's there. We'll give your mummy and daddy a little beeper that will make noises, and that measures the amount of radiation they're getting to make sure it's not too much.
How long do I have to stay in hospital?
You're likely to be in hospital most of a week to start with. It does vary a little bit from one person to another. We measure your radioactivity every day and we let you out as soon as it's low enough. And then you might have to come back in again for a second treatment about 2 weeks after the first. Every day, one of the members of the team will come and visit you and take some measurements with a little machine and take a reading on their machine to see how much radioactivity is left inside you. Every day there'll be less and less radioactivity left inside you. It will get to the point where you'll be able to go home. And it's a good idea to drink plenty, and that helps to flush any MIBG that isn't sticking to your neuroblastoma cells out in your wee.
What else will happen while I'm here?
Once you've had your treatment, we're going to ask your mummy and daddy to take some special measurements every hour or two. You need to be lying on the bed, looking up at the ceiling, just for about a minute. Nothing actually happens to you. All you have to do is just lie there still, and your mum will press a button on the machine and that will take the measurement. The reason for doing this is that we then know exactly how much radiation your body got the first time and how much radiation your body will need to have the second time. And we will also be taking you to the nuclear medicine department. So you'll go on the lift to the 5th floor and you'll have some scans done. Now for those scans you have to lie very still for a little period of time. The scan takes pictures of your body and it shows where the medicine has gone to. We want to be sure that the medicine has gone to all the areas where the neuroblastoma was. And to help you to lie still when you're having your scan, they will be able to project a film on the ceiling. So all you have to do there is look up and follow the story. And then the time goes by so quickly. It doesn't feel like having to lie still for a long time. I'll let you go now and you can go and have a look at the rooms. And I'll see you again in a few weeks' time when you come in for your treatment. So, I hope that has helped to enlighten you into the sort of situation a child and a family faces when they come in for MIBG treatment. Very often we find that families come with preconceptions which are wrong. People have told them about lead-lined rooms and they imagine that it's like a windowless cell in Alcatraz. People talk about isolation and parents can feel that they're going to be separated from their child for a period of time that might be like forever. But really, it's not an unpleasant treatment for a child to go through. Obviously, it would be nicer if they didn't need to have treatment at all. It would be nicer if they were at home rather than in hospital. But given some of the really unpleasant things that happen in other parts of the hospital, the time children spend with us is relatively stress-free. It's maybe more stressful for the parents, but the children quite enjoy it. So maybe I should start by declaring that I have no particular commercial or financial interests. My own personal funding comes from the UK National Health Service, the National Institute for Health Research, University College London Hospital's Biomedical Research Centre, and from the RadNet Programme of Cancer Research UK. But I would like to thank many different organisations for funding the various strands of research that I'm involved in, not least, of course, solving kids' cancer from both sides of the Atlantic and joining against cancer in kids for their particularly generous funding of a range of different clinical trials. So what I'm going to talk about, well, you've already seen the information video, and now I'm going to explain what molecular radiotherapy is, talk a little bit about MIBG treatment, a little bit about LuDO treatment, and explain perhaps how we can make molecular radiotherapy work better. And then I will run through in outline some of the clinical trials from the past, some that are going on presently, and some that we hope to do in the future. So to answer the question, what is molecular radiotherapy? I think the best way of thinking about it is that molecular radiotherapy is using radiation as a drug or as a medicine. So we have radioactive drugs, which once they're administered to the patient will stick to the tumor cells. This leads to high activities of radiation in the tumor deposits and relatively low levels of radiation in the normal healthy cells in the body. And the radiation then kills the cancer cells. This is in distinction from external beam radiotherapy, where an anatomically defined area of the body is given radiotherapy, and areas adjacent to that, the radiation has to pass through and can cause damage on the way in. So if you think about it, perhaps as some sort of rocket, a missile is the vector which carries the warhead, which is the radioactive component, and that is aimed against a target. One new word on the block that you might have come across is theragnostics, sometimes spelt without the G in the middle, which is a compound word created from therapy and diagnostics. And it refers to a set of radioactive drugs which stick to the same target, but one of them is optimized for diagnostic imaging, for scanning, to demonstrate where the tumor is and to show that the tumor takes up that particular vector, and the other one is optimized for treatment with a different radioactive element stuck to it, which has the appropriate physical characteristics to kill the cells. So neuroblastoma is really a paradigm for molecular radiotherapy. I mean, perhaps I should say that molecular radiotherapy is used for a range of other diseases. So thyroid cancer in adults and children has been treated with molecular radiotherapy with radioactive iodine treatment pretty much since the 1940s. And the vast majority of those patients are cured as a result of that. More recently, molecular radiotherapy has found real value in adults with neuroendocrine cancers like carcinoid tumor, and also there's an increasing excitement in its use for older men with prostate cancer. And as I get older, my risk of getting prostate cancer must surely rise, as it does for every man. And so I'm really hoping that my colleagues looking at that aspect of treatment make it work really well. But neuroblastoma expresses a number of different targets. So there is the noradrenaline transporter, which in America you might call the norepinephrine transporter, and that is what takes up MIBG. It also expresses, or at least many patients with neuroblastoma have cells which express somatostatin receptors, which can be targeted with somatostatin analogues. And as everybody who knows anything about neuroblastoma is very familiar with GD2, which sits on the cell surface and is targeted by monoclonal antibodies such as dinutuximab beta, and others, including 3F8. So really, you could summarize the purpose of molecular radiotherapy as using a drug to search for cancer cells and to destroy them. So MIBG is perhaps the best known example. It's been around for a long time, probably getting on for 40 years now since it was developed at Ann Arbor in Michigan, initially as an imaging agent. It's a catecholamine analog. You'll be aware that children with neuroblastoma are often having their urinary catecholamines measured. Catecholamines are chemicals like adrenaline and noradrenaline, or epinephrine and norepinephrine, that are produced by normal adrenal gland tissue and also by the tumor. The MIBG gets taken up by sympathetic nervous system cells by an active process through a molecule which we call the noradrenaline transporter or norepinephrine transporter. And these days, mostly we use MIBG labeled with iodine 123 for imaging. This has a relatively short half-life of 13 hours and produces good pictures the day after it has been injected. And we use iodine 131 for therapy. This has a longer half-life of about a week, and so the radiation has a longer period of time to get into and to treat the neuroblastoma cells. So over the 30 or 40 years that MIBG has been around, there have been extensive investigations into its use, and many papers have been published. And a few years ago, we did a systematic review in which we found and read every publication on MIBG therapy for neuroblastoma which had ever been written, and we looked at the results presented in those publications. And you can see from this graph that the top group demonstrated a wide range of response rates. Some of the trials had response rates of less than 5%. Some of the trials had response rates of over 70%. So what is the true response rate? Well, the average proportion who responded in these trials was about 33%, something like that. So about a third of patients who were treated with MIBG, when you look at all these trials together, responded. But I think the key thing to note is that the inclusion criteria for patients into those trials was very, very varied. Some people, particularly in the earliest studies, were very much at the end stage of life, were not expected to survive very long, and this was a last-ditch hope to try something. In other series, patients who were much earlier in the course of their illness, much fitter, were chosen, and they had longer to benefit. Also, the way in which the MIBG was given varied enormously. The amount of MIBG which was given varied very significantly. And also, how response is defined also varied between the trials. Now, of all the trials we looked at back in 2014, there were at that time no published randomized trials. All the trials were single-arm studies, typically institutional series with relatively small patient numbers. And if one is going to demonstrate that one treatment is better than another treatment, then really the essential thing we need are randomized trials. And I'll be saying more about randomized trials a little later on. So how can we make molecular radiotherapy better? Well, there are a number of possible ways. Some of these are theoretical ways, some of these are proven ways. Firstly, we can increase the amount we give, we can increase the dose. We can combine the MIBG treatment with radiation sensitizers, of which there's quite a different range. We can combine the MIBG with immunotherapy. We know that immunotherapy over the last few years has made a real difference in some principally adult cancers like renal cell carcinoma and malignant melanoma, and immunotherapy is now making inroads into some of the other common adult cancers like lung cancer, and it's being investigated much more widely in children with cancer as well. We might also be able to make molecular radiotherapy work better by attacking multiple targets. I showed you before that neuroblastoma cells may express several targets. Why don't we attack all of them either together or in sequence? But to make molecular radiotherapy work better, we need more basic science research into the limitations of molecular radiotherapy and how we can optimize it. And critically, we also need to have more clinical trials to evaluate the new ideas to see if they really do result in benefits for patients. So that is MIBG imaging and therapy. I mentioned somatostatin receptors, and these can be targeted too. The phrase that's often used is peptide receptor radionuclide therapy. And the theranostic pair we have here are, well, there are different things that can be used, but we use gallium dotate positron emission tomography imaging and lutetium dotate for therapy. And this is an established treatment in adults with gastroenteropancreatic neuroendocrine cancers. And the picture below is not, in fact, a patient with neuroblastoma, but it is a teenage girl who had a metastatic insulinoma associated with a genetic predisposition syndrome. And in the left-hand panel from December 18, you can see that she has multiple black spots in her liver. She received 4 courses of lutetium dotate therapy, and follow-up imaging in January this year shows that all those black spots have gone. So she had a complete imaging response 6 months after completion of therapy. But unfortunately, 6 months later in July of this year, and it may not be terribly clear on this picture, but there are tiny little spots beginning to grow back in the liver. So we have started to retreat her with the same agent. But this is an example to demonstrate that lutetium dotate therapy really works for some tumor types, and it's been shown in large randomized adult trials in neuroendocrine cancers that it very significantly prolongs survival. So what about lutetium dotate therapy in children? We started using this a little more than 10 years ago. Here you can see one patient, and in his left groin, he had a big lymph node mass, which after the first therapy administration of lutetium dotate can be seen to have taken up a lot of the lutetium dotate. Then we gave a second administration, and this has virtually completely disappeared. He also had a metastasis in the femur on the left-hand side, and that too has improved very significantly. And this child, some years after treatment, remains alive and well. I'm not saying that that is entirely due to lutetium dotate, but this certainly kept his metastatic disease controlled for a period of about a year. So nearly 10 years ago, we published our first initial pilot experience. We saw some encouraging results, but our conclusion was that this was still a very experimental treatment and a trial was needed. So that brings us on to the various clinical trials, and I'll talk about MIBG trials first before we come on to talk about lutetium dotate trials. So I said before that when we looked at the literature back in 2014, there were no published randomized trials. And so it is with great excitement that New Advances in Neuroblastoma Therapy ran a trial which was presented at ASCO this year that was a 3-way randomization between MIBG treatment alone, MIBG combined with chemotherapy in the shape of vincristine and irinotecan, and MIBG in combination with vorinostat. And the results of that so far suggest that the addition of chemotherapy to MIBG resulted in a very similar response rate, but with more toxicity. But the addition of vorinostat to MIBG significantly improved the response and time to progression. The other randomized MIBG trial that I have been involved in designing has been under discussion for many, many years, but has taken a long time to bring into clinical practice. We call this trial Veritas, which means the truth. And this is now open in France, and I hope will be open in the UK and in other European countries early next year. This is a comparison of two high-dose treatment strategies. Firstly, patients will have 3 courses of temozolomide and irinotecan, and then the randomized options are either 2 courses of MIBG with topotecan or high-dose thiotepa, both followed by peripheral blood stem cell rescue, and both followed by busulfan and melphalan, and then standard local treatment with surgery and radiotherapy and immunotherapy. And this is a trial for patients who do not respond well to induction chemotherapy. So this is a trial for refractory disease. Minivan I won't dwell on because I know that Juliet Gray will be talking about this after me, but I think this is a very exciting trial for a number of different reasons. Firstly, it combines the power of molecular radiotherapy and immunotherapy. Secondly, it is supported by the Embraced Consortium, which includes Solving Kids Cancer, both America and Europe, and also Joining Against Cancer in Kids. So we're very proud of this trial. It's now in the 2nd cohort of treatment. It is open in the UK and also in Madison, Wisconsin, and I hope will be open in Germany very soon as well. Looking ahead, this is a concept which hasn't yet come to a trial, although we're asking for money to run it. It's a trial which focuses on a subgroup of patients with neuroblastoma who we know do rather badly, those with ATRX mutations, and this combines MIBG with a drug called olaparib, which inhibits an enzyme called PARP. I won't talk more about that now, but hopefully this may be the first you've heard of a new venture for the future. In terms of lutetium dotate, we have published this year the results of our phase 2 trial of LuDO. The headline is that none of the eligible and evaluable patients showed a response, and that was rather disappointing given the patient that I've shown you before who wasn't in the trial. But we did note that in 3 patients, the MIBG scans did improve after 2 courses of treatment, even though they might have subsequently progressed. I think the problems with this were that we weren't using a high enough dose because we were scared of toxicity, but in fact the toxicity was very limited, indicating that higher doses are possible. And this has led to a new concept of LuDO-N, which is a new trial being developed in conjunction with colleagues in Scandinavia, the Nordic Pediatric Hematology and Oncology Organization. Compared with the LuDO trial, this will give higher doses over a much shorter overall time, and we hope that this may overcome some of the limitations that were inherent in the recently published LuDO trial. So in conclusion, I can say that molecular radiotherapy on the face of it is conceptually very simple. It's just like climbing up to a high board and diving into water. It looks so simple, but actually in practice, it's really quite difficult to do. So finally, I would say that molecular radiotherapy has got a lot to offer patients with neuroblastoma. At present, the treatments we use are not fully optimized, and further research is needed. We need basic science research, we need translational elements, but above all, we need more clinical trials. So I would like to thank all the people I work with at University College London Hospitals and many other people, and in particular the funding bodies and charities that we work incredibly closely with.
Cool. Thank you, Mark.
Thank you.
So we have 10 minutes to take a few questions. There are 3 here on a similar theme, so I'm going to try and take them and give them to you all as one. So I have a question that says, what are the side effects? The second one says, is there any data on secondary cancers such as leukemia? And then there's another question, do all children's immune systems recover 100%? And if they do, how long does it take? So if we could start off with those 3 as a group.
So the side effects vary depending which particular type of treatment you're talking about. Let's talk about MIBG first. So the short-term side effects could be nausea and vomiting, but we're pretty good at preventing that with antiemetics prior to treatment. The longer-term side effects, although we with thyroid blockade to reduce the uptake of free iodine by the thyroid gland, there is a risk if people survive for several years for them to develop an underactive thyroid. Now that isn't really a big problem. It's more on the scale of being a nuisance. It requires thyroid hormone replacement therapy once that's been diagnosed. Apart from that, there aren't really a lot of side effects of MIBG therapy beyond myelosuppression. Historically, we used to give relatively low dose MIBG, and if patients had repeated courses, then they could end up with thrombocytopenia and anemia and neutropenia, which never really got better. That was partly down to the MIBG, but also largely down to the very extensive prior treatment those patients had had. Nowadays, we nearly always have a stem cell harvest first. We give a higher dose of MIBG because that will be more effective, and we rescue them with peripheral blood stem cells. Yes, there is a risk of second malignancies, but if you don't successfully treat your first cancer, then the second malignancy risk doesn't really matter. The second malignancy risk will only become significant when we get to the stage of treating the majority of patients. I have to say, though, that in my experience, second malignancies related to MIBG therapy are relatively rare. I've only seen 1 or 2 cases. For lutetium dotate therapy, the side effect profile is different. There can certainly be an effect on the blood count, which is different from the effect of the blood count with MIBG in that it tends to be much more gradual, not so severe, but more prolonged. So in our first pilot study, we found people whose platelets dropped, not down to dangerous levels needing transfusions, but went down to perhaps between 50 and 70, but never really got better even if you waited for a while. The other theoretical side effect of lutetium dotate therapy is renal dysfunction. And of course, many children with neuroblastoma already have impaired kidney function as a result of prior treatment. We know that if you administer a solution of amino acids at the same time as the lutetium dotate, the amino acids stick to the tubules in the kidney and they stop the LuDO sticking to that. So we haven't actually seen any renal toxicity, but that may be more of a risk as we increase the dose we give. I think the probably the problem we had with the LuDO trial, which we did for the best of reasons, was that we were so desperately keen not to cause toxicity and side effects that we didn't give enough, and we spread it out over too long a period.
Thank you.
And the immune recovery, I'm not quite sure is the answer to that. Certainly in Minivan, we will be studying the immune parameters in blood tests very extensively over time, so I'm sure we will learn more from that.
Thanks, Mark. We've got another question here, actually related to MIBG scans. What radiation risk does regular MIBG scanning pose? And this is asked from somebody who says they have found a difference of opinion between US and UK clinicians on this.
So I think in the most ideal world, you want to avoid the exposure of children to radiation because of the risks of causing cancer. But all risks are relative, and you need to balance the risk that you might cause from the benefit that you might gain. So I think it would be quite wrong, for example, for every child with tummy ache to be sent to hospital to have a CT scan to look at their tummy to make sure there wasn't something there, because that would involve thousands of children receiving a dose of radiation for very little benefit. And that would be a bad thing to do. When you have somebody with high-risk neuroblastoma who is facing a very poor prognosis to start with, the small risk from an MIBG scan is completely justified if it helps you treat that child better. And so at the beginning, you want to know where the disease is. Once you've given chemotherapy, you want to reassess that. When you get to the end of treatment, assuming everything has gone well and your end of treatment staging shows no disease, there is indeed controversy as to whether you say, well, let's keep scanning because we know the disease might come back, or maybe we should just stop scanning now. Let's try and allow the child and the family's life to be as normal as possible and to reduce any risk from additional scans. And those who don't want to do the scans would argue that if neuroblastoma relapses after full treatment, including high-dose therapy and immunotherapy, then by all contemporary standards, they are incurable. That doesn't mean to say untreatable. Second remissions can happen, but it would be exceptionally unlikely to really cure a child and return them to a normal life expectancy if they've relapsed after full treatment. So that school of thought says that there's no benefit from doing a scan. Other people would say, well, if you do scan very frequently, you may pick up disease at a time when there's perhaps just a single metastatic site and they're potentially curable. And that's an interesting viewpoint. Whether it's actually true or not, I don't know. And I think this would be a very fruitful area to do a proper scientific clinical trial to find the answer.
Thank you. We've got a couple of minutes left, so I'm going to try and just run through as many of these, if we short question and answers as we can. Can you only be considered for MIBG treatment if you are able to have your stem cells harvested?
That is certainly the ideal, but it's not absolutely necessary. If you have no stem cells, then low-dose MIBG can be used for palliation.
As a child grows older, does the risk of side effects reduce from MIBG scans?
I don't think so particularly.
In terms of dosage of dotate, how much more dose are you thinking about giving in the new trial? Are there any plans for when the new trial will start?
So, as I said, the new trial is being led from Scandinavia, and it's gone to the funding bodies there. So hopefully, if that's successful, it will start sometime next year, and will then spread to other European sites, including the Netherlands and Britain. We're probably trying to give twice as much.
Twice as much, thank you. And so one last question before we close the session. Do you have any thoughts on the peptide receptor radionuclide therapy trial at MSK that's using 67 copper sartate?
I think there are a variety of different ways of doing it, a variety of different theranostic pairs. I think this is very interesting.
Thank you very much, Mark. So I'm going to close the session at this point. Thank you again to Dr. Mark Gaze for presenting and being with us this morning. We've reached the end of this session. We have the ongoing transitioning to adulthood session ongoing, and the next session in this stream is minivan, MIBG and antibody combination therapy. If everybody wants to go back over to the agenda page and start viewing, and I'll see you there shortly.
Thank you. Goodbye.